we would have pre-conference symposium.
Go anywhere because there's no planes taking off. So you can stop right there. Ruby, just come out here so we can explain what happened.
Yeah, come on. We can easily explain it to you. We're your friends.
I don't know you guys. Explain there.
Fine.
Of the Republic of Kenya. Evening for the opening. So we'll run the process, but of course his presence is here. Two, this is our KNDI headquarters. We keep on improving every day. Right now here we have a full broadcast of nutrition, purely nutrition. So very soon you'll hear the podcast and then radio, TV, and then TV. So we want it to be purely nutrition oriented, where people come and talk about nutrition to Kenyans. We have had many people who go to the mainstream media and they speak things that appear like nutrition or they sound like nutrition science, but it's not. So we want to vet those who are coming to speak to Kenyans about nutrition. And the best way is that after we have installed ours, we'll advise the Media Council that we don't want any nutritionist to talk in public if they're not approved by us. Is that not okay? Because we have had people who say that lemon is alkaline in the mouth and acidic in the stomach. And from your basic chemistry, you know that is not correct. So, and it is on air now. So we are going to do that here. Our conference will run here with exhibitions also. So I'm just telling you that everything is good. And you'll enjoy the conference. When we are opening, maybe you'll get more. So I want to take this opportunity, first of all, to welcome two institutions here. That is Kenyatta University representatives. We have the head of department here and the team. Maybe You can wave or you introduce your team when they're here. We'll find time to introduce one another. Then we also have Bumbe Technical College. Mercy is here. Mercy, you walked alone. Your principal is very mean. See, Kenyatta has come. There are 5 of them. Mercy is just one person. I'll just call him immediately. After this, he will come for him by himself. I know he's in Nairobi. So you're all welcome. We also have Thika School of Medical Sciences. They also came for other meetings, and we have just finished their meeting. They are also here, led by the director. The director is somewhere. Yes, she's there. Thika has campuses across the country, Kisumu, Mombasa, and main campus. And they're also approved training institutions. So having said that, you're welcome. You can just come and sit. Having said that, I want to run this pre-conference symposium. And just want to say, why did we have to think about this subject? And the subject is strengthening preclinical competencies. And I want to give a story that, we train health professionals and we expect them to attend to us, isn't it? We expect them to attend to everyone. Daktari, I know I've not introduced you. Your time is coming. Dr. Mumanyi is from Kisii University, so their time is coming. And she's also one of our chairs for the conference. So I said, if we train professionals that come out, we know the current environment is about social media, and they can attend anytime to the entire population of Kenya and beyond with their knowledge. Also, when you go to the health facilities, you find them there, and they attend to it as with different procedures at every ward. For example, if you talk of Kenyatta, we have several wards, so they attend to us. The question is, the person who is attending to us, are they competent enough to attend to you? Or would you run away if you see them approaching and they introduce themselves? I'm Dr. Keo. Okay, I'm Mr. Keo. I graduated from Kenyatta University, got first class honors. And from today, I'll attend to you. I'll perform some procedures for you. And one of the procedure is that what I've carried here is a cannula and surgical scalpel. And I want to insert peripheral, maybe cannula, into the peripheral end. Will you accept or you run away? I think that's the question we need to ask. And that is what I was asking also the Thika School of Medical Sciences. Will you run away from your students? Or will you say, I'm very happy because I know your competencies were well grounded? We lack that in many institutions. And so nutrition is important. And more important than anything else in the medical profession. How many of us agree? Nutrition and dietetics. The problem is that nutritionists are always shying to say that nutrition is the most important. But not me. I think now in the Ministry of Health, when I walk into the door, they know the nutritionist has come, including the cabinet secretary, they know. Why is nutrition important? 70% of all health problems have their roots from nutrition. So when it comes to NCDs, even infectious diseases, they have their roots from nutrition, poor nutrition. Let me give you an example. In my case, from 2009 until 2 weeks ago, I was not seeing anything far. That's partial blindness. That's me. And I'm a nutritionist until the discovery came. And I got a regimen. Now I can see. Are you hearing me? I can see up to 20 kilometers I can see from here. I was not able to see. I'm talking to now those on glasses. It's possible that you can see. But issue, I'm telling you, I was on glass, I left, and being a pastor, I said I can't be on glass and teach about healing, but I was still having it until 2 weeks ago. Now I can see. I hear it. And the regimen is very simple. I have the recipe. I'll give you to go and try it. Okay? It's purely nutrition, no cataract, no surgical. Everything is back to normal, which means that nutrition can reconstruct if it is properly guided by wisdom from above. So we must fight this war of nutrition position countrywide and in the sector so that people don't take it for granted. It's not cooking. It is a science. So I was telling the chair after I got back my site, I was telling him, you know, this is what you used to enjoy when you had full sight. And I could see M-Pesa, Safaricom. I could see the writings, the billboards. I came to the express road and I saw how beautiful Nairobi has been. I was not seeing it. I was seeing some clouds. You get that? That's purely nutrition. But we don't want to take our position for it in the country. So let's then start. I hope the slides are prepared. We can show them on the screen. The studio, can we do that? Is it possible? Or I can just go through? Can you have the slides on the screen so that as I talk, just 1 minute if when they're organizing themselves. Martin, you can check that. If you are using Zoom, you can just put it the way we normally do. The slides are on. In a minute, we can go on. So as the slides are coming, this is pre-clinical skill strengthening of competencies for nutritionists and dietitians. And I've added their integrated approach. Before they put the slides, why did we call it integrated approach? The therapeutic team in a health facility, where the one we call frontline therapeutic team, is normally made up of a team of health professionals. So previously, we used to have a physician consultant leading the team, even up to now, correct? And they're talking with shoulder high because they say they went to school. And then we had physicians in that team, and then the nurses. Then we had the pharmacists. I don't know whether they still go ward rounds. We had also people in the laboratory as such. The most interesting thing is that the physician and the consultant doctor wanted to be seen as the one leading the team. And so they scared everybody, such that when they cough, everybody runs. The nurse will be running to go and get what they want. The nutritionist will be shocked because of the terminology being used. And the others will be like, what is the consultant saying? Let me tell you today, they're not consultants. We are all consultants. So we have a nutrition consultant, a physician consultant, we have a scientist, we have laboratory consultant. So we have one unit called therapeutic team member unit. So a doctor cannot start, a doctor cannot start a ward round without a nutritionist. That would not be impossible if it was to be ideal. So with that in mind, during our inspection of facilities that are training, we came up with what we call integrated approach in preclinical learning, where we insisted that all institutions must have a skills lab, where we learn preclinical skills prior to service delivery. And this skills lab was supposed to be a learning lab for all frontline health professionals, including a physician, a nurse, like that, a nutritionist. So in that skills lab, we don't want nutritionists to be taught alone. We wanted them to be taught alongside the nurses so that they act the ward when they are in the preclinical as a simulation. So what happens in the ward would be done prior to service. So then the nutritionist would appreciate that the nurse is my team member, and the nurse would also appreciate the same, and also the physician. And now we call it integrated learning. Why? So that I can know the language of the nurse, and the nurse can know the language of the nutritionist. So if it is ABCD for nurse, we also have ABCD for nutrition. And when that happens, we say, then let us have a prototype of a ward with all the activities in campus before service. And so we came up with integrated skills lab approach. And that is why we began the journey of strengthening. Now, what did we find out? We found out that when we are inspecting, many institutions didn't understand the concept of preclinical skills, competency building, and therefore they were building skills labs as a ritual to meet the requirements of a regulator. So if the regulator says we need a skills lab, they would go and get something from the shop. Some of them were getting even the cloth mannequins. You've seen them on the streets. And they were putting them on bed and covering them, saying, this is our patient. And if you touch like this, you hear the sound, and you ask whether there's any human being that can make that sound when you are reviewing. And we found that some even bought them at very high cost. They were very expensive when they were purchased. So we said it can't go like this. So we came up with the concept to introduce the real mannequins that meet state-of-the-art requirements. And that is why these ones are here. Thank God we are doing this when KU is picking their mannequins. And with this, then, we realized that even the schools of nurses didn't have. We visited KMTC countrywide. They didn't have a skills lab. And they were training nurses, nurse aides, they're training nutritionists, laboratory clinicians. We visited universities, didn't have. And not all universities had prosected cadavers if they don't have school of medicine, but they were training nutritionists. We also looked through even medical programs in private, they didn't have. So we said, let's give them the option. You can get through us. The only problem I know is that if you can access also on your own, it's good. But the specifications are given, and they have to be really those. So these ones are high fidelity mannequins, particularly when it comes to the caregiver ones. So we'll be talking about that. So are we ready now? So we can have the slides. So the first question is, why integrated learning? You can go to the second slide. It is essential to take note that all the BSc graduates, all BScs, that is from the universities, must undertake 7 hours a week of concentrated practicum in a clinical setting at an approved health facility, equivalent of level 4 and above, all the graduates. In line with this, professional teaching in nutrition and dietetics, therefore, have to allocate time to support service delivery at the health facility. If you are a lecturer teaching in a university and you are a professional, the only service you can offer in addition to the teaching service is when you deliver direct service in the nearest health facility alongside with the students. That is when you can have impact of doing, because you read, now you should do all that appertains to the degree that you have acquired from time to time. And on equal note, qualify for all allowances prescribed for cadres such as non-practice allowance. So, and also risk and extraneous allowance. These are things that our nutritionists have been battling with, that how comes we are not getting these allowances yet the nurses and the medical doctors are getting. It is not how comes we are not getting. How have you proved that you need to get? Because we are not found in the clinics. Most of the nutritionists like suits. So we don't like lab coats and scrubs. We don't find ourselves in the facilities. When we send our students, we send also preceptors that we think are at that level to practice. But the patient in the hospital need your knowledge on nutrition more than the student's knowledge. And then you can now qualify for risk because you're taking risk to be in the hospital. You can also qualify for non-practice because you could have been practicing and yet you have been occupied by Kenyatta University, for example, and the facility. So you have to get non-practice allowance. And also extraneous, because then you're doing more than what the university engaged you for. So then you can get extraneous allowance and even health service allowance. So the only way to justify those allowances is when you are in the facility. And that the allowance doesn't come from National Treasury. It comes through the Ministry of Health. And that is why we are not getting yet. In Kenya, nutritionists are classified as medical professionals under health professionals classification. And if you are in doubt, then the Health Act under Section 60. Paragraph 2 says groups nutritionists with clinical officers, doctors, nurses, medical technologists, pharmacists, among others. So we are all grouped in that category as medical professional. Thank God for those who have nutrition in agriculture, but still in the health sector, the alignment is medical profession. And so we have joint delivery of service through Kenya Health Profession Oversight Authority. And so we qualify for all joint health allowances. But we have to prove it when we are found on duty in the health facilities. And there's a rotation indicating very well that you are part of it. Specifically, regarding Nutritionists and Dietitians Act under Section 3, it requires that nutritionists practice privately. So all nutritionists are supposed to have shops where they can practice privately. And the idea is that when you practice privately, then you can have that knowledge transferred to those you are teaching, because you'll see cases that are real and use them as case examples when you're teaching. So every nutritionist should have a shop. And if they can't do it on their own, they should have a nutritionist plaza, just like the doctor's plaza. But we have never thought about that. So when Barwechu comes from Kenyatta Hospital, we expect her to go to the plaza and attend to people who have eye problems, like who had eye problems, like, okay. So that is it. Now, with that said and done, KNDI preclinical competency guidelines aligns with the Ministry of Education competency-based curriculum approach. Right now, we are going to receive those who have done CBET, correct? Very soon, have the universities aligned to the competency-based component of training, have the colleges aligned. And so we went ahead and said that we have to do this together with the Ministry of Education. And so we are aligning this, and that everyone will have the competency component inscribed or mainstreamed in their training. And so in our case, with the prescription, the policy or the guideline, for example, focuses on maximum 1 year equivalent. If you read the Nutritionist Act, it talks about internship being 1 year of hands-on before service. Now, it is our model that we can either have it as supervised internship or concentrated. Concentrated means that while they are training, they can go for attachment, for clinical visits like that, until they make it 1 year. And this is in line with the Nutritionist Act. Now, the key areas that this focus on include 7 hours weekly concentrated practicum. And this is a matrix that ran across certificate, diploma, and degree. Now, when we talk of degree, we are working with approximately 5 or 4 hours. Why 3 years? We're assuming that the SYMBET curriculum will not allow you to go for 4 years. So the degree will take 3 years. And because it starts on the first day of admission, it will give us 5 or 4 hours. For the diploma, we are approximating 2 years, and that is 336 hours. And then certificate is 1 year compared to what we are going to have. So that is our prescription. The other thing I wanted to agree maybe with the president, that why do you have to take 4 years to build a competency? You can still take 3 years if we concentrate competencies with intense hands-on. But that one is left for the academia. They can argue out and see why can the brain capacity handle all required within those years. The second one is developing clinical attachment guidelines, which is equivalent to 672 hours, normally 12 weeks. Now, attachment has become a ritual for training colleges and universities. So people go and then the lecturers get facilitated. Nowadays, even they're not facilitated. They really struggle to go with their money and come back to claim. Very unfortunate. And no one else knows who awards the marks when it comes to attachment. So from the KNDI model, we are saying that the nutritionist will be followed from the attachment. And that means that when they go for attachment, we will be in picture and we'll do a remote assessment alongside the attachment. At the same time, the lecturers will also go for attachment. I know Doc is not very happy with me there, but we have been saying that the lecturers must go for attachment to know what is new in the field, so that they can go and make notes that are aligned to what is new. A new case has just been discovered. The Gen Zs have come to class and they are pointing out a case that you have never seen, and they are outweighing your capability. What do? You must also be up to date with them. The AI has come and they are ahead of you with knowledge. While you are talking about the textbook center, and then textbook content. They're already having the knowledge at hand and they're challenging you. So we must also go for attachment, even if it is 3 weeks attachment. Then developing community attachment guidelines. You know, when we send these people to clinics or they go to NGOs, they only align to the NGO's objective. And you cannot change it because they have given you the opportunity for your students to be there. Yet this is a training. So it means when we are engaging NGOs or community centers, they must also align to the focus of the curriculum, what we need, so that the supervision can be aligned to the integrated collaboration. Now, these guidelines must be given to all that host our interns or attachees so that they are aware. And then when we assess remotely, then that would be giving us a true picture of a competency built from any student. Now, how do we assess? If you look at what we have prescribed in hours, the degree holder would do 8.25 months minus assessment, which means that it's equivalent to the 1 year we have prescribed in the Act for hands-on competency. The rest can do less, because of their levels, and that is not guided by the law, but at least it's giving them an upper hand in competency. Now, how would this be assured? There's what we call building a portfolio assessment criteria. We have started, because that's why we are indexing students, that every student that has joined campus or college must be indexed within the first 1 month. Now, once they are indexed, they will be in our database, and then we will have direct contact with them. Now, when we have direct contact with them, we will assess them remotely. So they will build what we call a portfolio platform. We have been talking with one of our partners, and also we expected the Ministry of ICT to be part of this process, where we combine hands to have a bigger database where we'll carry all data for all students. And so they will be from time to time going into that portfolio system and deposit any competencies they have acquired. So if they go to a clinic and they have performed a procedure, they have to take a picture or a video clip and load it there in their platform. And also when the assessment is done, it is loaded in their platform. Now for us in KNDI, with a team of faculty, we will look at those portfolios and assess them and award them marks remotely. Now, by the time you graduate them with a first class honors and another one with lower, ours will be to compare. If the competencies were good for somebody who got lower, it doesn't mean that they are poor. They're as equal as the one who obtained first class. Now, if the first class one does not have better competency score, then they cannot be the market demand product. So they have to be enhanced. That portfolio assessment will be done in video clips and also attachment report. So that now we demystify this concept where one person awards marks for the students and say that this is what they have obtained. That is coming very soon. And so competence orientation will be very important for us. The good thing with the KNDI is that we always go ahead even before the future. And that is where we are at the moment with this. Now, KNDI has recorded 85 training institutions that offer nutrition and dietetics. Martin, is that correct? They're now 90. Okay. And based on our inspection reports, which we have done across all the 90, the institution has continued to emphasize on the need for preclinical skills, lab, Then the other one is skills lab, which is purely in health facility. We are saying if these people are supposed to go and deliver service, do they have enough competency? Because the news, bad news we used to get from the facilities that our professionals are half-baked. It's a common knowledge in the health facilities. And those who went ahead before would want to prove that the new graduates don't have content. And so when they go to the clinic, they will be given a test of the practical and they fail, then they are demonstrated at preclinical level to make mistakes there with this kind of a patient. Then they fail and they say, okay, these are the students we get from Kenyatta or Maseno University. They can't even handle a basic case of maybe oncology. So that skills lab area is another area that we want to build competencies for the professional. So far, some institutions have attempted to set up skills lab according to their thinking. And sometimes it is by how much you have to purchase this, the mannequins and any other equipment. So you go for anything that can come and you say, now you have a skills lab. But is that the objective? Now, when we did this, we said the institute reviewed all areas of clinical competencies and recommended basic mannequins, which are specified according to the demands of our training, which is bare minimum. And we say that this is going to be for standardization purpose, so that a student from Thika Medical School speaks the same language as a student from North Coast Medical College when it comes to preclinical competencies. So if you get your mannequin that does not have the competencies prescribed or cannot give you the value needed, it means your students will be different from the other one from another campus. And that is why we said it is important that we purchase this at a central point. That is why some universities did. Some have purchased on their own. Some are close, some are having their own things. So standardization comes in when you have one resource. And that is why even before we did have one curricula to be taught. We called it KICD, K&I curriculum. And we also had university minimum core, so that you don't teach your own things, you can only add. So we decided to standardize the preclinical skills. And after this, I think in the next 3 or 4 months, once the council is gazetted, we're going to have a guideline for practical aspect of these mannequins that will be shared with all training institutions, so that when you have a manual, you use the manual. You don't use your Googled knowledge. I think that would be okay for us. So because of that, we have come up with these preclinical skills bare minimum simulators. So why use simulators in training? I know sometimes back, one of the nurses, I think is a nurse PhD holder. You know, we all go to school. Nurses didn't like PhD, but nowadays we have so many. So one from Megaton said, we no longer use mannequins to train because new methodologies have come up. That's well and good. We still need mannequins. And even if it goes to the level of AI, we can still have mannequin demonstration through AI technology. Simulators are used in nutrition and dietetics training to provide safe, controlled environment for practicing skills, bridging the gap between theory and clinical practice, and developing essential technical and non-technical competencies. Many times, many institutions have told us we use JOTRH hospital for clinical competencies. Those are facilities receiving patients, correct? They're also receiving human beings, true? You cannot use a human being as a guinea pig, as a test tool. And so there's no way you can use a facility to learn preclinical skills. We only use a facility when we have acquired skills now to demonstrate service under supervision. So all the mistakes that are being made must be done at the preclinical level. Now, this allows students to learn from mistakes without real world consequence. If your students goes to kill a patient in a health facility, there are two things. One, if they're not indemnified, then it's criminal. So then you have to be put to task and pay. And the facility that hosts you can also pay. So that's a high risk. But if they come and kill this mannequin, nobody will complain, isn't it? You are looking for a cannula, a vein, and you are poking. No problem with the mannequin. You can poke as many times as you want. But I bring you my hand, and then you start poking here. You try that seems better. You go to another one. That somebody can kill you, isn't it? So we need to look at it like that. This allows students to learn from mistakes, build confidence also, and practice rare but critical scenarios like parenteral and enteral nutrition. We learn those ones when we are at preclinical level. So you can know how to even demonstrate insertion of nasogastric tube, or how to insert a cannula, or how to team up with another medical professional to do a surgical process for that cannula. So we want to see the benefits of using simulation in training. Safe learning environment is number one. They allow students to practice complex and also high stress situations repeatedly without risk to the real patient. So they can make as many mistakes as possible. Also bridging theory and practice. You apply theoretical knowledge to realistic scenarios. And that reduces the gap between classroom and real-world clinical setting, so that we avoid this comment, you are just full of theory and no practice. Now, when it comes to skills development, we have those technical skills that are acquired during this preclinical skills learning. And when you talk of high fidelity simulators that can mimic human anatomy like these ones, then allowing students to practice tasks like administering IVs, like what we have, or performing a CPR, and responding to changes in patient's condition. If that is done early, you'll be comfortable with that student when they come now to attend to you in real life. They are also used to develop critical thinking. Critical thinking is a technique that we avoid. And you cannot critically think in class when you're waiting for another lecturer to come with the mathematics and calculus. And another one is also going to come up with the philosophy. But the best way, if you now go freely in the clinical setting, which is mimics the hospital, now you start thinking critically, because you can be put in groups to think about a case and handle it there. Decision making, teamwork. When we talk of integrated learning, a nurse is here, a nutritionist is here. So they begin to know that we are all one person attending to one person. No superiority. And then leadership skills, how to engage in teamwork for realistic scenarios, and debriefing sessions. And you can imagine if they are learning together and the nurse is there and they're briefing one another on the patient who has come and how do we handle this patient. It will bring that language of healthcare provider or patient-centered healthcare provider approach when they now go to practice. Otherwise, if you graduate them on their own, they will just meet in the hospital and they ask them, what did you study? Some say, I did nutrition. Another one says, I did nursing. You ask them, which act of parliament regulates you? Oh, we are regulated by Nutritionists and Dietitians Act. Another one says, Nurses Act. What is there in common for us? I don't know. But if they knew what is there for us is that patient for all of us, then that would be a good approach. And they can build confidence. So we say it increased confidence also. Practicing in a simulated environment builds self-confidence and self-esteem. There's nothing as bad as being ambushed with a technique or a procedure that you don't understand. But if you are used to the procedure with simulators, it becomes very easy for the real patient, which are crucial in clinical judgment when we are faced with the reality of a real patient. Where the first time we were introducing our students in the university, that is Maseno, to prosected cadavers, 4 of them collapsed and fainted. We took them to the hospital. The first time, because they saw the head. And like for me, I had one head in my office. I don't know, they used to say is the head of Professor Onyango, the late. But it was growing hair there, and you can easily see it. And I was comfortable with it. But when students saw it, they collapsed. They said, we are not supposed to be here. This is not nutrition. Now, the first time we came, we told you that. All lecturers were running away. They were saying, no, that's not our area. So we insisted that people must go to the medical school and we must learn nutrition there. So self-confidence and self-esteem is very important. We have one nutritionist I know somewhere, I think it's Bungoba, that stands face-to-face with a physician consultant and says, consultant, this is not for you. You don't understand this. Let me show you how it's supposed to be done. That's a confident nutritionist. And you can't scare them with the drug terminologies because they have gone through drug index in full and pharmacology. So they understand. So we also look at the evidence-based approach. Of course, in that case, we are looking at practice of rare events. But when it comes to evidence-based approach, simulation or simulating training has been shown to improve competency and evidence-based practice for better quality, because this is where you present cases and deal with those cases on a dummy. And then, of course, we are saying in the current AI, what is coming is that the AI will make it even easy to engage simulations in training of our own students. And so that's a new area that researchers need to look into. So that is that. So I want to just take you through. Now, what we have here that Kenyatta University will pick is just a bare minimum simulators. We have several simulators that can be used for different trainings, even for nurses and nutritionists and others. And particularly this one is bare minimum for nutrition. And the nurses can also use it. Clinicians can also use it. So when someone gets these, they can offer all courses at preclinical level. It combines both the basic anatomical parts of a body and also the caregiver simulators and children or infant simulators. And I will run through number 11. If you move the slide. Can we move on? Just go ahead, the next slide. Yes. So if you look at your left-hand side, we have this long mannequin, which is unisex. And why unisex is training institutions may not have enough of resources to buy female and male at the same time. So it's only about changing body parts, and you have one single mannequins. Mannequins are not cheap. They are very expensive. So if you have unisex one, then it is better for you when it comes to resources. It can do many things, almost 16 functions or competencies for the nurse. In fact, the nurses benefit more on this than the nutritionist. However, the nutritionist can review the feeding processes, nasogastric, including the basic vitals, which are required for every medical professional. And when the nurses are doing their business of competencies, the nutritionists can also learn those competencies, so that we have a nutritionist who has an idea about what a nurse does. And the nurse can also learn about the feeding processes. It has all competencies needed for a nurse to train, and all competencies needed for a nutritionist to train and to study. Then the next one is also there. The next one is a 3-year-old. Can we move to the next? Sorry. It's not, sorry. Before that, we have a hand. Just hold it there. Now, this is called the blood pressure training arm, and it can read the systolic and diastolic. And when you talk of this, it can also allow for pulse rate, including adjustments, being done or demonstrated with the students. And it can help the students learn vitals, how to take vitals, even if they're not directly medical physicians or nurses. It is looks like a hand, and it feels like a hand. You can puncture it, not plastic. Of course, they're canvas, but they can be punctured, and you can demonstrate the test. The next one is a 3-year-old. Can you go to the next? Yes. When it comes to infant management, the nurses take lead, but the nutritionists also have a say when it comes to feeding processes. Now, when you talk of ostomy care, for example, when you do a surgical process for you to insert a catheter, is ostomy. It can either be jejunostomy or gasostomy or gastromy. Now, that thing requires care, isn't it? Now, it's not only the nurse who should care. What if the nurse is not around and something is happening, the sepsis is coming up? Don't you think a nutritionist also need to know how to clean the wound and continue with the service? It's possible. So you'll be asking, is a nutritionist allowed? Now, at the regulatory level, we are doing what we call integrated management of healthcare. So all boards, we have agreed that we will work as a team, and therefore nobody's bad. The last time I was sorting a case in Thika level 5, a doctor tore a paper file that was marked by a nutritionist on the basis that they're not qualified to write something on the file. And we went there, and I was not very interesting, the medical doctor. That is when they understood that they need a nutritionist. So, clocking or writing on the file, everybody has a section and equal opportunity to do so. The same will apply to cross-cutting basic competencies. It's not task sharing, but cross-cutting. Do you have to wait for a nurse to clean a hand when you want to give food. You can do it as a nutritionist and it will work. The next one is a CPR. A CPR, no scientist in the medical field can fail to have a CPR techniques. Purely is a simulator that helps our students to understand how they can do resuscitations and all those basic first aids. And this is electronic. It can cough, it can do other things, depending on how you are skilled. Then the next one is infant. We normally call this baby smart, a baby that can do many things. If you go to some institutions, they have bought canvas dolls from the supermarkets, and they have put them lying on the bed very well, saying that now we use this one to train on breastfeeding. But you need a real baby. This smart baby can do many things, can be instructed to do many things that a baby would do, and can be used to properly train. They are there. We will look at them there. So we insist that there must be an infant, then a child, then an adult as bare minimum. So that when you're dealing with issues to do with infants, you focus on the baby. So you don't use the adult mannequin to train on infancy. And you cannot use infant mannequin to train adults. And then finally, the next one is the hand with a feeding system. This is IV, intravenous, which can either be medicine or nutrition or food. You know, many people don't know that normal saline is food. But Rachel, do they know in Kenyatta Hospital that normal saline is food? But who takes the lead? Of course, in other facilities, who takes the lead? The pharmacist, yes, and even the others, they think that that is medicine. Now, let me ask you, who allows them to be in the country? Is the Pharmacists and Poisons Board, correct? Where did they study food? No one has ever thought about it. We must understand that feeding is possible without stomach. And that is why we use this system to demonstrate how somebody can be fed for a while when the stomach is still under development. And you can do that intravenously and they can survive. I remember Professor Nguka had one patient here in Nairobi Hospital who took about 6 months without food in the stomach, but was going through parenteral. Of course, the patient finally died, but the fact remains that the disability adjusted life years were enhanced. Then we have the last one, which is the skeleton. Now, many times skeletons are found in many labs, but sometimes it's good to have a skeleton that can separate ligaments from other components of the body. And this is one of them. So those colors depict different things on a human skeleton. So it can have the muscles separated from the ligaments. Now for the anatomical, that is for basic training, that is mid-level, who do not have the advantage to look at a real cadaver to see the positions of different aspects. And of course, even a real cadaver may not show you the position. We recommend they have also the anatomical models for the body parts. And we have 3 types, male, female, and unisex. So when it comes to the male, of course, that is 19 parts. They are there. And when it comes also to the female, We also have a tin. I think there must be 15 parts. The unisex one have also 19 parts. What does it say? Does it mean that females are not the same as men? Maybe we'll discover that when we're training. So that is the bare minimum that we need. Now, in addition to the mannequins, when we're building competencies, we must also ensure that we know how to take measures, that is body composition measures. What we knew from our training was when you have a stadiometer, that is a height board, and a weighing machine, you can calculate the BMI. But now the technology has gone far such that this can be done in real time. Like this one we have here is for our own. We use it for the community. And it can give you reading, you can print out very fast, and it can also show you what you have as a body composition, including the visceral fat and overall fats, so that you can know that sometimes when you are thin, you can be more dangerously unhealthy than the one who is fat. Okay, the one who is big. Because the other thin one is fat, so the one who is big. For example, Mercy, you are going to beat me up. Your body, you can realize that you may be more healthier. Who is the thinnest here? This gentleman here. Hello, sir. You can stand here so that you see this one. You might think that he's thin and looking good, but when you do maybe before you leave during the afternoon, you can all take that. Yeah. This one can be more unhealthy than Mercy. Sit down, sir. Asante. Because you might find that the fat level is about 37%. I'll check what you have, which is far much higher than what is required. And then you say, don't grow big because chances are that you're a risk to NCDs. This could be more risk to NCD than Mercy. If we find Mercy is big and the visceral fat is less than 17%, who is healthier? Mercy will be healthier. Now, the former one cannot give us this nature of body composition. So when we are training and when we are also offering services, we must get the right equipment. You can use this as a training institution also to make money, because you can do this as a consultancy for all the community members. And the money you generate from there, you buy mannequins and buy books. Now, the other one you see there can do all tests when it comes to biochemical. It's also a nutrition tool. Liver function test can be done by that. It's a very basic tool and can give you a number of outputs which are blood oriented. And that can help also the nutritionists make proper decisions. They're not just for medical physicians at the facility. You can also have them in the nutrition clinics, so that you have this and you have that and many others that we have not mentioned. So in nutrition field, we have a number of things that are needed for competency building. Now, when we go through this, chances are that we can be the only solution to the health sector. You may doubt that, but I know it is. And the medical physicians know, and they don't want to accept it. They also know that nutrition can take them out of the industry. The pharmacists, they know if proper nutrition is brought on board and people are feeding well, then they are out of market. So they will fight it to the tooth. That's why they are all on CSS necks at Apia House, because they want theirs to be sorted. But if you are and you choose that you want to do away with curative, you focus on the primary healthcare, will reduce the number of patients going to health facilities. We have a case here of 9 years diabetics on drugs. 3 months of our intervention, no drug. 9 years, it was 8 point something. diabetes. 3 years, 3 months, reversed. So maintenance is what is needed. It means nutrition can still help this nation. And every person on earth is a nutrition case. Everybody in a facility is a nutrition case, including medical doctors. They are nutrition cases. So then we have to train better nutritionists when we build the competencies. Can you clap for me? You know, once a teacher remains a teacher. And I'm very happy that, do we have a few questions before we move to the desk? You can come here and take questions.
Kindly hatupati sauti.
And she was like, it's so easy, but I sit with nurses and I can do it. And I stopped her. Another student, this is the last example, then I can raise my question. Another student went to level 3, like a maternity center. And together with other nurses, he was taken to the maternity ward. And he was told to work with the nurses and start conducting deliveries and all that. He called me and I told him, you cannot do that. You can observe, you cannot do that. Now, having listened to the extensive explanations here, we're being advised to like observe what the nurses do and the other clinicians do. But my question now is, what I've been pondering, and that is the reason why I when students call me, I tell them, don't do this, do this. My question is, what is the scope of our work as nutritionists at the clinical area? Because when I was looking at the Nurses Act and their scope, if you give an immunization and you do it wrongly, in quotes, they are protected. What about nutritionists? That is the question I wanted us, like, we ponder about it and maybe discuss. Thank you.
Thank you. Is there another question from Daktari?
I'm stand. I think it's better. The chairman of chairperson Department of Food, Nutrition and Dietetics, Kenyatta University. I want to appreciate the CEO of KNDI for that detailed information he has provided, especially for the mannequins and their use, and to go along enhancing our teaching, but also training them. Now, I think I have directed to the CEO. You some of the proposed, especially for training in the degree, certificate, and also diploma program. And I saw one of the degree program, which was that it takes 3 years. Yeah, it would be good that, yeah, we can be able to achieve 3 years, because of course, our students sometimes even question why we are teaching. So we are taking too long in the system, like 4 years, some even because of retakes, they end up doing even 5 years, even other 6 years, which we don't, of course, promote, but we try our best that they can graduate in the 4 years. Currently, our department, we are able to have our students graduate in 3.5 years, yeah, because we're offering more units, 8 units, previously 7 units per semester. I know we are in our department, we have several units, 57 actually, for the student to complete, including the practical units. So I don't know, we can try, but I know 3 years may be a bit the students for them to accommodate everything, and especially when we have so many units in place. That was just my comment. Thanks.
Yes, let's invite Doc once more to respond to that.
Yes, Dr. Mumanyi, what you are asking is why we joined up under Kenya Health Profession Oversight Authority. The unfortunate thing is that the people running it don't run it the way it's supposed to run. And I have no apology for that. If we are going to have a therapeutic frontline health team, there was a document that was being prepared, which we rejected. It was called task sharing policy. We rejected it on the basis that it was going to be used by a particular cadre to suppress other cadres. But the ideal was our regulators were to come together and find how many bare minimum competencies would be required for every cadre as an emergency, if the other is not there, to perform a function that is required to attend to a patient. For example, if there's no nutritionist in a health facility, can the nurse take nutrition assessment and do classification the way it is needed? And so after that, those basic competencies were supposed to be concentrated in the teaching under clinical skills so that they can be allowed, but under observation. So we have not reached there yet. And so they agree, but there are some facilities that allow even insertion of catheter, of nasogastric food tubes. And I know nutritionists who have done that successfully, and they are protected. If they are arrested, that's why KNDI is there. That's why they are indexed. That's why we are there for the professionals also. That is what is called professional indemnity, apart from the insurance indemnity. So it is something that we need to work on as a nutritionist and other health cadres. It can happen when we have an integrated learning. The other question is on, is it possible to have 3 years? You know, my thing is that sometimes we do too much. You know, you don't have to take somebody for 21 days to learn driving. I think so. I once had someone flying an helicopter who never went to any aviation class. But we're also not saying that there's no need for sanity when it comes to standards. The content, the problem we have had with the curriculum, particularly in the universities, is that every person, can we have a better mic? Every person who went to study, they want their area studied. Let me not use them. Everyone who wants to study, they want their area to be studied. So if I study, I will look at the curriculum and ask how many courses to be put there. So I prescribe 5. And I say those ones must be there. They are very important in the clinical area. And we cannot do without. Another one comes with community nutrition and wants to put 5 courses. Now, in competency-based approach, we are looking at what we call that, the end product. It's occupational what? Occupational standards. We define the competencies and the usability of this person first before we get to the curriculum, and then teach competency. So that you don't bring in clinical dietetics 1, clinical dietetics 2, clinical dietetics 3. What are the key dietetic competencies needed for a competent professional in nutrition? Then concentrate your curriculum on that. You'll get what is needed. And they must be hands-on skills. Now, the theory is good, but it's only to make somebody become a manager because they can handle many problems. But it's not necessary. I studied calculus. I was very good in mathematics. What is calculus helping me to do now? I'm not using it. Okay? You are doing business, sir, but you did quadratic equation. What are you using it for? You get that? So we are loading so much that is not necessary. We want human solution. So let the training focus on human solution. I want someone that can bring someone back to life. What do you need? The competencies that will make that. So the curriculum approach needs to change so that we define a curriculum for 3 years. For a degree, it's possible. If you go to the other countries outside, degree is 3 years to become a nutritionist. Now to become a dietitian, you add 1 more year. Because now you concentrate on dietetics. So we can still train. So let us rethink, define competency first, then define the curriculum. That means occupational standards first, then curriculum. And that is what the TVET is doing. So you will still have a job. And if possible, get competencies cutting across. And 3 people who are teaching different things can teach the same thing, 3 people. Same one course with 3 people. And the best approach in teaching at a university for me, if I was to be appointed a VC today in my university, this is what I would do. 1 course would not be taught by 1 person. You will come teach your topic that you need. Then I come and teach my section. So, that if I come with 1 topic, I share with you because she was requesting I'm a lead
Tuna attachment.
Don't be intimidated with that. Just write to us. You know, if you're implementing on your own because your boss has intimidated you, then you suffer alone. But if you write to us, we will ask your boss. We'll advise you copy to the boss to see. And they will take a break. You know, if I'm appointed today, I have my own interest. And if people come to my office and tell me, let us change this thing to this modularized, I will just write a circular. Circular is not law. Are we together? So you write to us, we will respond to it. And if you want to know what I'm talking about, it's correct. I can call the person in charge now on loud and ethical so that she can tell us when did you start implementing this. So don't be intimidated. If you feel it is not correct, write to us and justify why. We have institutions like North Coast that have never undertaken NEC exams. And they wrote to us and we told them, you'll do your own exams and we'll license your professionals. because they said NEC is examining construction instead of nutrition. And they brought documents showing that. So you ask the regulator, you are regulator. I don't know about other boards, but ask your own regulator and we will respond. So for nutrition now, we only approved CINDA curriculum. Now we are yet to approve them in modularized state, but no part certification. And then when it comes to modality for implementing from level 5 to level 4, that one we have to agree. We have not agreed yet.
Thank you, Dr. for the presentation. I would actually agree that the idea of preclinical skills training is long overdue. Gereso Eric from Kenyatta National Hospital. So I agree that preclinical skills training is long overdue. Maybe on the comment around lecturers coming for attachment, I would rather if you can work a way in which those who are practicing could also now like level up with the trainers, so that more or less you can have a harnessed approach in terms of delivering content to the learners. Because you find a situation whereby now a student has come from class, now maybe what you've called textbook training. Now, of course, they have got that backing from their tutor, whom now they trust in. Now they've come to the workplace where now you have real-time touch with the clients, like the mannequins. But then it's like, you see, they remain kind of torn in between, whether what they've had from now the hands-on person or from the class, where they more or less kind of become confused. So I think we can actually think our way through in terms of how do we leverage between the practitioners and the trainers, so that we can have actually a harmonized playground. Because at the end of it all, these students you're training today will be our caretakers tomorrow. Because if I find myself admitted in a hospital, then now the only person I'm seeing next to my bed is a student whom I saw. Now, whose knowledge are they using? What I share to them or what they were trained on? Thank you. So thank you.
Other question? Okay. Let me answer that one. I think it's a comment for me, isn't it?
It was a comment.
Yeah. And do you accept that lecturers should go for attachment? Doc is looking at me and saying, it's okay on normal, really. Don't you think lecturers needs to go for How? You don't want to go to the university to exchange? You have not applied for masters? Oh yeah, the CMCs, they call them CMEs and CNEs, CMEs and CME, both of them. So you want, like when you have such series running, then the lecturers also come and run. And also you can also organize some in the universities. That is the ball is in your courts. It comes. That's why we have the MOU for health facilities.
Yeah, I think I really welcome it myself, so that those who are especially also teaching the clinical units can also be at the same page. Because once in a while we get those comments, especially when we go to assess our students out there, that maybe sometimes they have not, the way we have done it is not what is practically being done. So that is the hands-on experience would really want to have. How it can be done with the universities.
So you want the big brother to bring the policy, isn't it?
Sure thing.
So very soon you will see a regulation. That's what you want. The council is coming. So the first thing is to come up with the integrated learning approach regulation, which will bridge the gap between knowledge, skills, and practice. Actually, it's in one of our panel discussions for this conference. So it will come out there very well, because the industry is going that way, the academia is going that way, the NGOs are also going that way. These people must be brought together so that they speak the same. Yeah. And also, someone is implementing acute imam, another NGO is also implementing imam. Why can't all the NGOs come together and implement imam? Those are things that we need to have a conversation. I think it's okay. We will come up with that policy. Thanks for giving us the idea. And you know how we like policies. And we'll provide technical support. And that's money.
Yes, good afternoon all. Thank you, Dr. There's a question that Dr. here from Kisii University asked about the 3 scenarios she gave about feeding of patient and a nutritionist student was told to go to obstetric ward to help a mother give birth. Yes, I was interested really on the issue of feeding, because in KNH, yes, we don't feed patient, yes. And sometimes our students could be told, do this. So what is Nutrition Act saying about that? Thank you.
You cannot do it unless we are given a framework for it to be done. And that's what I told you we are working on as regulators. So I told you that the driver is very slow. You know, you can have somebody driving a trailer, another one matatu, and so they don't drive with the same frequency. If this was to be done well, by now we would be having the bare minimum shared areas, which are still indemnified within the acts. So it's not, you are correct, it can't be done. Yeah, somebody should stick to their line first, and then the shared competency. How would you feel if a nurse now comes and they want to now give a nutrition care process wholly? Will you be happy? You can't, yeah. We're done. So we want to give chance to Kenyatta. Sorry for taking your time. And Bumbe. So that they can say something, and then if you want to and these ones I can assure you, if we do use them well with the competencies needed, we will come out with better students. So that Shitati doesn't say that they're half-baked. Doc, your students, they say that they're half-baked. Then we can hand over to them, and we discuss. We convene again in the evening for the bigger thing.
Thank you, CEO, Kenya Nutritionist and Dietitian Institute. Now I've introduced myself before. I'm Dr. Juliana Kio. I'm currently the chairperson at the Department of Food and Nutrition and Dietetics, Kenyatta University. I feel honored and privileged to stand before you and take this opportunity really to say something about this occasion. I know the invitation was done such that our VC would attend this function, but because he's committed elsewhere, then he sent me to represent him here. So kindly, CEO, accept his apologies. I'm going to really give a short speech on behalf of this VC, and then just give a few comments as a chair of the department. So to the CEO, Kenya Nutritionist and Dietitian Institute, members of the KNDI Council and the Secretariat, representatives from the Ministry of Health, if they are here, and representatives from other organizations, here Kenyatta Hospital, Kenyatta National Hospital, and others are also present, and of course, many others. Distinguished guests and pre-conference participants, good afternoon. It is with profound honor and privilege to stand before you today on behalf of the Vice Chancellor of Kenyatta University, Professor Paul Wainaina, to celebrate the important milestone in the advancement of nutrition and dietetics training at Kenyatta University. Today's event is not just a ceremony of recognition, it is a reaffirmation of our shared vision to strengthen professional standards, academic excellence, and practical competence in the field of food, nutrition, and dietetics. On behalf of the University Management, the Department of Food, Nutrition, and Dietetics, and on my behalf, I extend our heartfelt appreciation to the Kenya Nutritionist and Dietitian Institute, KNDI, for granting us accreditation to the Department of Food, Nutrition, and Dietetics. The degree program was first accredited in September 2015. That is when we received our first accreditation. And subsequent renewal of the license in May 2021. And of course, this now current September 2025 is the third time where the renewal was being done. And one of the reasons, of course, why we are here to receive our renewed license. Maybe you can also clap to us. The accreditation by KNDI signifies trust and confidence in our programs, a validation that our curriculum and its delivery, as well as training facilities, meet the professional benchmarks that prepare our graduates to serve effectively in various sectors of food, nutrition, and dietetics. As a university, and more specifically the Department of Food, Nutrition, and Dietetics, we are committed to continuous improvement to offer the best quality of training and to align our training with both national and global best practices in nutrition and dietetics. We wish to particularly acknowledge and appreciate KNDI, in particular the CEO, for the procurement of the mannequins here, which are quite costly, but the university committed to invest into this vital teaching and learning resources. We are especially proud to note that Kenyatta University is the first university in Kenya to procure the mannequins for use in the Department of Food, Nutrition, and Dietetics. Maybe public. Thank you for that correction. The first public university to procure this. And we thank our university management really for the commitment and support to the department. The introduction of mannequins marks a new era in practical training, as the CEO has just said. It enables our students to acquire essential clinical and practical skills through safe, realistic simulation. And I would want to say we are going the simulation way a lot because it's also very friendly and also cheap for training. These resources will undoubtedly enhance our capacity to deliver high quality hands-on training that meet both national and international standards. As a department, we will continue to nurture competence and ethical practice for nutritionists and dietitians. Will play a critical role in addressing the health and nutrition challenges facing the nutrition in the region. As a department, we look forward to being a center of excellence in training in the Kenya region, but also in the African region, and stand out really. And I know as Kenyatta University in the department, we already stand out in Kenya. We look ahead and we envision a dynamic partnership where Kenyatta University and KNDI work hand in hand to build a strong foundation for the next generation of professionals, men and women, equipped not only with knowledge, the classroom knowledge, but also skills, hands-on, with integrity, compassion and deep sense of responsibility to serve humanity. On behalf of the VC, I once again convey our sincere gratitude to the CEO and the entire KNDI team for your leadership, collaboration, and continued support. We look forward to strengthening this partnership as we both work towards a healthier, well-nourished, and productive Kenya. Finally, on my behalf, I want to appreciate KNDI for inviting us to this pre-conference symposium. We really feel greatly honored for this invitation, and we wish you a successful and fruitful conference after this. Thank you, and may God bless you. And I think because we are a team from KU, I would really request that I introduce the other team members who we work closely. You can come, kindly come to the front. It's a strong team who are working on programs. Of course, others could not get here. We represent them as a department, but they also really work very hard to make sure that we get this accreditation, renewal of the certificate. And I would request them to introduce themselves. I think we can start.
Okay, good afternoon. My name is Regina Wagoi, and I'm part of the team that was trying to work to get the accreditation, but my area of specialization is basically clinical nutrition. Thank you.
Good afternoon. Rose Wahome, also part of the accreditation team and a clinical instructor in the Department of Food, Nutrition and Dietetics, Kenyatta University.
Good afternoon. Yes, my name is Dr. Eunice Jogu. I was also part of the team that was working so that we got this amazing license, and particularly or specifically, I'm usually the one who coordinates the curriculum in the department. Thank you very much.
Thank you, team.
Now you stay there. So, I think very important. It is good to acknowledge that Kenyatta University has done very well. I know there someone here who studied in Kenyatta thought he was the best nutritionist when he was making noise. He also studied there and used to be beaten thoroughly. Let me recognize him. Michael Odero is the CEO for the Nutrition Union, that is CUNAD. I think he's in the house. He didn't introduce himself. Michael, are you there somewhere? Is he online? He's online? Just left. We also have with us here Professor Onyango. Prof, online. We have
Yes, I'm
Edna
online.
Warento and Emily Wahome is a member of accreditation committee. Is also present. I would want to recognize also, we have about 424 online for this. So it's a big team. Sometimes COVID can be said to have been a blessing, because you can imagine if you had all the 400 here, who would give them water? Now where you are, you can take your water and we are safe this side. So the few who are here, you'll get a bottle of water each. Now, I have to do this honorably. We appreciate the fact that the VC sent you. They were supposed to come physically. The notice was a bit short also. And we also want to deliver the license or approval. Let's call it approval because of the new terminologies in the legal, so that you can train again for the next four years. Kenyatta scored very high. I think they are at 90 plus, 96, 94. And for you to get 94 on KNDI standards, you must have worked very hard. That one I can assure you. Because we lead, others follow, and our standards, one VC said they are hitting the roofs. So if Kenyatta did that, that's okay. So I'll want to give this officially, maybe so that I'm not alone. Okay, no, you can be this side. My team can be this side. Those ones with the t-shirts written KNDI. Elizabeth is our registrar. She's the one handling all the professionals with the licensor. And Anthony is in the examination unit. You're making me to feel jealous that I don't have a t-shirt. This is not very good. You know, this is the CEO talking. You can go home. But they look very smart, isn't it? Good. So this is KNDI team, and we are handing over this official. University. No, Martin, it's okay. We are okay. So this is official. Thank you very much for being good students. Thank you very much, Karibuni sana. We can have a seat. Yeah, the next one is Kumbe, you can have this. Let's allow them to take some. We'll tell the VC we'll come and take a better photo. That's okay on site. See how good it is. Yeah, good student. Thank you.
Just as I'd introduced myself, I'm Madam Mercy Okwaro. I'm a trainer for nutrition in Bombe National Polytechnic. And I know in the program it's indicating Bombe Technical, but we upgraded and we received a charter to be a national polytechnic in October. So we are proud to be a national polytechnic now. It's located in Busia County in Samia sub-county, the backyard of Dr. Julia. So when she was here, she felt that Bombe cannot be left out. So that's why we also started nutrition. And we have gone through the whole processes with Daktari here since 2015. And we appreciate the way he handles the nutrition department. It's not a joking area, so we always strive to ensure that we do our best. We were supposed to be here with our principal, Mr. Callistus Wanjala Omilo, but he was held up. We also have visitors in the institution that required his attention today. So he sent his apologies. I hope it is received. And in Bombe, we have the nutrition department that has 4 staff, and we are currently handling around 180 nutrition students in diploma and in certificate. During our accreditation, the nutrition team KNDI have been coming around, and true to their word, we have dolls, we have the fashion design, what do you call it? The models. And actually, it is true, it is not easy to train with it, because even if you tell them to put it on the length board, it's just there. So we had also thought about having the mannequins, but when we looked at the budget and the cost, even if we checked online, the budget was always very high, and we would always still push it aside. So when we received communication from KNDI that they can be able to help us procure the mannequins, we felt that that was a better deal for us. I know we were not able to procure the whole package, but we started with some, and in the next financial year, we can still pick the next package so that we have the whole. the whole package. But I know it will go a long way with improving the training in the institution. During our orientation in the hospitals, we take the students to the hospital, but we realize so many of these hospitals also do not even have these mannequins. But at some point we visited Alupe University, and we got Alupe University with them, a few. And our students were not leaving that skills lab. And we were seeing the interest in which they had. So I'm very sure that if these mannequins land in our institution, it's really going to improve the zeal of the nutritionists in learning this course. So we want to thank KNDI for helping us get them and being patient with us until we were able to make all our payments. Asanteni. I think I don't have much to say. I just want to request them that they open up to all the other institutions so that we have the same and we use the same everywhere. Because these students, when they go around, their brothers and sisters are in other institutions. And they will always tell them, in our institution, there is this. In this institution, there's this. So for us to be able to be at par and train the same, I believe we should all have the same. Otherwise, I want to thank you. Asanteni san.
Mercy was coming to receive the mannequins, so it's not licensed, but they are licensed. Yes, so Bumbe is accredited, and Thika will be soon accredited. You know, you are learning notes, you're taking notes. With that, I think we need to move there so that we can finalize this. One thing I know is if you become a good student, then you produce also good students. This one was my student, and I keep on pushing her that you must be the best. Yeah, so even at masters. So I'm also contributing to humanity. Don't just look at me that I'm looking for money from mannequins. So so we are coming to an end, just a few. Maybe we can move here for those who want to see what we are talking about, touch, but you don't touch too much because they belong to someone else. So that you can see what we are talking about, high fidelity mannequins. I know we can get so many other mannequins, but it's always also good to go for quality. When we are in our training institutions, mostly the procurement department, they are very hard on what to procure because of what they get. And so chances are that they can always get you what you want. But these ones we had tested and tried, it can do quite a number of things, even enteral feeding and all that demonstration. You can change the female to male. So it's unisex. And you can also do the vitals measurements. The same applies to that. Now, if you get that hand, study, that one is soft, isn't it? Yeah, so it's different from those other things that we normally use for clothes. So they are also called mannequins, but these are high-level training mannequins. These ones are electronic. You can do CPR and they can cough. You can see how you press and it goes out. So it's again very easy to manage both the two. That's full body. This is half. That is a half body. This is a quarter body. And then for the children, we have that. And then the 3-year-old is this one. Also, this one you can do enteral feeding demonstrations. You see, it's anybody who handles this, if they go to the hospital and they meet a patient, they cannot be scared because they will assume that it looks like, and all patients are treated as dummies. Let that not be recorded. We called, if you go to North Coast Medical College, they were using, in addition to mannequins, they were using dummy patients. So you pretend to be a patient in their procedures. Now we don't encourage dummy patients. We want people to use this, and then we treat people in the hospital. And these ones are now just add-on. These are anatomical models for teaching. Many times, if you ask many people, where is the position of the stomach? they will tell you that it's down here. There's no stomach. Down here we have intestines. The stomach is actually up here. So it's good to know which position is really the stomach and the liver and how are they arranged. So this system can help somebody have an idea of what kind of body they are dealing with. So the whole of this set is for KU. Bumbe's, we have kept it somewhere there. So after this, they will pick them. But they also have bare minimum from this, which can be used. And it's good for those who you want to train. You can also start college. Don't just stay at job. Very soon, number one, will not be paying people. You have to look for your own money. So you can also start a college and train people. And we train many Kenyans. We need 60,000 nutritionists. We are only at 15,000, and we have trained for 15 years, which means that it will take us another 40 years to get that. Now, don't ask me where are they going to work. They can work privately, and it is allowed. So this is so officially, I want Daktari, you and your team, you can receive this. After this, they are going to repack it for you in the boxes, and you can call your, I think you came with a bus. You didn't want them to stay here even one day for other people tomorrow. Yes. So all the tools, you'll go item by item so that you are sure if all what you order is there. And then inside here, we have things like battery and the rest. They're all packed together. Good. Yeah, but this is not the final. The entire thing is 2 plus taxes, 826. Now the problem, actually they're 400. The problem is KRA. when you bring them, the KRA doubles. Yeah, but if they can, we are negotiating that in future, they give us for without tax. Then it will be very cheap, but it's very difficult. KRA. So, yeah. So the whole 14 sets is for 826. Now, if you are going for the burns one unit for burn is 500,000. I don't think we don't need to have that for now. But in future, for advanced training, like for masters, you may need those ones that if you connect, you can see blood is flowing and you stop them coagulations. Those ones are very expensive. Yeah. So that's okay. So this is also an exhibition. We thought we were going to use KU ones to exhibit. You can pick your things. Sorry. Now this one is what I was telling you that you can actually come here and stand and get your instant requirements. Yes, but it's not connected. It has to be connected to power. And it can give you in a nutshell, when you just stand and look, you'll know content. And it's very nice. It's real time. It's just like it's also bioelectric impedance analysis machine. So you need these ones also. This one is going for 100. Yeah. If we are the ones getting you, I don't know, you can also get it from the market. That one is, I think, is 146, but that one can do liver function test and all that. Quite a number. Yeah. You have the other one. We also have that one, yeah. But this one is now different. This was very nice. Yeah. We are using it for the community around. You know, we also have to open a shop because they will be asking us, what is this government institution doing here? They come ask us for sodas for Masuja Day. They also come and ask, can you treat us? So we have to do something because we have nutritionists here. The same to that. When we go for medical camps, we also carry these ones. Yeah. Good. So that is it for today. Martin, is there anything we are supposed to do? So we want to appreciate all of you. We didn't have chance to introduce one another, but at 6, we are convening here for the opening, and we'll have a mocktail. We don't take alcohol here. So we have prepared something for all of us, and we open the conference, and the conference begins officially tomorrow. It's very intensive. We have many abstracts. We are even wondering whether we'll finish, but we have about 70 people to make presentations, which is really very high. And very interesting topics. I've gone through them as a scientist, so I'm very sure that people will learn here. And it is you people who have written, isn't it? Yeah, so nutrition must go for. I'm trying to explore whether on Friday we might have the CS close. So I'm still exploring. I've just written to him. He's a very good friend. He's doing good work. You know that? He's hands-on. He's si mchezo. And he also knows that mimi pia si mchezo. That is not Kiswahili. So we are all fighting for common good for nutrition. And I can assure you, very soon, this subject will attract many students. And the chances are that we are also going to be engaged in on matters of employment. So the labor mobility report, I think the PS has a final copy. And that would be very good also for our profession. The union is also doing very well with pushing the agenda. I think they are very close to the payment of interns who went to court, very close. So those who did towards 2017, they are likely to get their money from the ministry. Yeah, that's why I don't know why he ran away, but they're doing very well. So thank you very much. No more questions, so we can disperse.